Okay, welcome, Pahrump. I'm Dr. Michael Reiner. I understand that this has been a kind of a rebroadcast and a taping. This is the live section of the show. I got hung up in the office as I usually do on a Monday. It's always tough to get out of the office. We're been extremely busy. And part of the reasons we're extremely busy, it's end of the year type of medicine. Things are trying to get caught up. And of course, as you know, I kind of went on a tirade last week about this Class 2 Schedule 3 issue, and I'm still on that. It's created over a burden on the healthcare system. And I am going to bring that up and bring the congressmen's names up. It's a future thing that I want to do to let you know who to write to and who to complain to if you happen to be affected by this. But suffice to say that there's been an increase in the number of patients that have to come in every month on an otherwise overburdened healthcare system. But the last time we had this show live, we were talking about diabetes, and I wanted to go back into and bring that up and talk about treatment. I left off a little bit right at that particular point, and so if we could go to a slide which I have listed all of the different types of treatments, and we break it down into obviously diet and exercise. This is one of the big things that we always talk about, and it really is the primary factor behind everybody's treatment. Whether it doesn't matter what I do for you as far as medication, if you don't restrict your diet, there isn't enough medication to control your blood sugars, and you will eventually succumb to this disease and its effects and as it wreaks havoc on your body. In addition to that, exercise is obviously one of those things that people don't do, but we need to think about exercise, and the reason why that is because if you actually exercise and actually were to eat correctly and exercise, you could burn off everything in your body. You wouldn't need insulin because, as I've said before, in a muscle cell, once the sugar has been used, more sugar will cross over into the cell membrane. It's a pure osmosis. And remember, insulin, whether you have it or you don't have it, whether you're a type 1 or type 2, insulin deficient or insulin resistant type diabetes, you have insulin, but it drives sugar into your fat stores. It does not necessarily drive it into your muscle cells. Your liver is the other organ that plays a big function in diabetes and gluconeogenesis, which is glucose forming and also storing of glucose in between your meals. And as we unravel the diabetes model, that's where we get our different treatments from. And so going into the medications, we can break them down into different groups. And as you see on the slide, you have insulin sensitizers, and we'll talk about those. And then you have secretagogues, which are another type of medication. And then you have analogs, insulin analogs, which are actually insulin. And then you have what's called the alpha glucosidase inhibitors, which are a product that not a lot of people are aware of, and that have been an old medication, and they're not using those. And then some of the newer things on the market, which of course you poor people get deluged on the TV of all the new commercials about diabetes, the SGLT2 inhibitors, and I'm going to break these down into each of the categories to try and explain them to you about how they work and why they work. And so let's talk about the insulin sensitizers. These are named called biguanades. Now I know that really doesn't mean anything to you, but that's the class that they're in. And as you know, metformin is the most common used of the biguanide medications. In fact, it's really the only one that's out there. There are different forms of metformin, long-acting, short-acting. But suffice to say, metformin has been one of the oldest on the market, second to what we're going to talk about later, sulfonylureas, but that's in a different category. And these basically, metformin was initially designed to be taken in the evening to basically eliminate or help your liver to store insulin, and so that you didn't secrete insulin during the night while you were sleeping. They found that it also could work during the day, and so they used it during the day. The only side effect from metformin, really, there's several, but the biggest one tends to be GI. People tend to have, sometimes they either can tolerate it or they don't. They get diarrhea, they may get intestinal complaints, other complaints. And then obviously renal impairment is one of the issues. If you have poor renal function under a certain limit, usually they call it a creatinine of 1.5 or greater. Some people will actually go 1.3, depending on your body size and your habitus. It can build up and cause problems with your kidneys. They always stop it prior to you having a CAT scan, especially if they give you dye. And so it is not, other than that, it's a pretty well tolerated, it's a very weak medication in that sense. It can be used with insulin, and it probably can be used with everything. And as we go into these other medications, some of the pharmaceutical companies actually combine it with their products and come up with interesting names to describe that. So it's used with just about everything, including insulin, and it's very well tolerated, has a lot of history except for those few people. The next group that we're going to talk about is basically the triglyceride products. These are also insulin sensitizers. This is a product, this is a group of medications where I don't have a lot to use these. I mean, you'll see the names under there, Actos, Avandia, and Resolin. The only two still on the market are Actos and Avandia, and Resolin was removed from the market shortly after it came out because it caused liver failure and death. I have never been really infatuated with these products. They are insulin sensitizers. It's kind of really unclear exactly how they work. Actos has been linked to supposedly bladder cancer. I certainly, in Actos in higher doses, is contraindicated in people with congestive heart failure. It does cause fluid retention. If you're on Actos and are swelling, it needs to be brought to the attention of your primary care doctor, and it needs to be reduced. I tend to use it in very low doses, in 15 milligrams. The link to bladder cancer is somewhat questionable, but you'll see the lawsuits advertised on TV. Certainly if you're a smoker or have been a smoker, that's one of your greatest risks for bladder cancer, and I would suggest that you always talk to your physician, and if you have had a history of bladder cancer, certainly do not take Actos. If you have been a smoker, I would think we'd look for another product that could be better for you without that. So while the history is unclear and the link is unclear, sometimes it's better to be safe than sorry. The other product, Avandia, of course, was linked to some type of increased risk for heart attacks. It's still out on the market. I try not to use it. I took it when I started hearing that. So there's not a lot in this group, and I would suggest that you really not make it a part of your regimen unless you're having trouble tolerating all the other prescriptions. Okay, let's go to the next group, which is called the secretagogues. These are basically medications they're called sulfonylureas. They've been out since the 50s, as I understand it. There's a first generation and second generation. These medications really do, they whip your pancreas, so to say, the beta cells in your pancreas to make extra insulin. And they have a limited action. The problem with that is they work all day long. Usually they're twice-a-day medications. You have to be able to make insulin, and they help your body make more insulin. Obviously, the downside to that is they make your body's pancreas producing mechanism, it poops it out even faster. So this is why a good diet is important. The other risks to these medications, and I thought they were going to reduce them in their usage, is they can cause hypoglycemia, which is low blood sugar. And remember, these are working without you being aware of that. So let's suppose you were to take one of these products in the morning and you forget to eat lunch. You're going to get low blood sugar. Or if you take it in the evening and don't eat much for dinner, you're going to get low blood sugar while you're sleeping. And that is very dangerous because you get increase in blood pressure. You get a norepinephrine effect, which means you go to a fight or flight where you become weak, pale, and this is could be a risk for increased heart disease and heart attacks because of this increase in insulin response, as well as low blood sugar and what it does to your system. I don't like these products. They make you gain weight. They are weight gain, and so because they're making you make insulin, they keep you hungry, they keep your blood pressure up. But insurance companies love them because they're cheap, and they love for you to take them. So they call it the first-line therapy. I will use them in rare cases only when the patient really can't tolerate anything else. I try and stay away from them. One of the risks with type 2 diabetes is weight. If you're overweight, which most people are, this is your risk for type 2 diabetes. So what do? We give you sulfonylurea because your insurance company wants you to take it. It's cheap. We force you to gain weight, which makes your diabetes worse. So we just kick the can down the road. Isn't that what our government does? Don't they kick the can down the road with all the financing? And hopefully we might see some changes in Washington with the elections. But that's just a brief point. Okay, let's talk about the next group. These are getting into some of the newer products. These are called secretagogues also. These are big names, and I know they may be somewhat confusing for you, but these are dipeptidyl peptidase 4 inhibitors, or short for DPP4 inhibitors. And you may know these products. You've probably seen them on the market, on the advertisements, called Januvia, Tradjenta, and Onglyza. Some of them are being advertised. I think Januvia is being advertised pretty heavily. Basically, their mechanism of action is to increase this hormone called incretin, which inhibits glucagon release. And glucagon is one of these hormones that basically is opposite of insulin, and that it does increase insulin secretion, and that delays gastric emptying. So these products are pretty weak, but they are very effective. These are weight loss, weight neutral drugs. I like them because they help to sensitize, even though they're called a secretagogue, I do believe they help to sensitize your body to use a little bit, to use your insulin a little bit more efficiently. By delaying gastric emptying, they tend to keep your sugar low by not being absorbed into your intestinal tract as fast. And you can simulate that by and I've said this before, eating a few almonds before your meal can also, the protein in your stomach can help delay some of the gastric emptying and your sugar level. So just having a few almonds might be certainly more enjoyable and cheaper than taking these products. I do like these products. I tend to use them. Their downside is obviously they are expensive. Not insurance companies don't tend to like them. They have to be adjusted according to your renal function, except for Tradjenta. Januvia has to be decreased if your kidney function is reduced. Tradjenta is probably the strongest affinity for the incretin system, and probably the product that I tend to use the most in my practice. The next product on that list is basically called the GLP-1 analogs. The GLP-1 analogs are injectable analogs. They are not oral medication as the previous group was, and these products are, as you can see in the bottom of the list, Victoza and Byetta. Byetta was the first on the market, and it is injectable twice a day. Then they came out with a once-a-week preparation recently, and Victoza is once in the nighttime. The side effect that's greatest with these particular medications has been nausea, and that's why they suggest that you take it at night, but the once-a-week Byetta doesn't have that option, but Victoza is one of these things that gradually increases. It's injected every day. So now you're getting into the fear factor of an injection, but it is not insulin. It doesn't lower your blood sugar when you don't eat. That's its benefit. Byetta with metformin is very weight loss. It's one of these strong, I see a lot of people losing weight when they use this particular product. When they go off of it, their weight tends to go back up. It is not a weight loss mechanism, and please don't ask your doctor to put you on an injectable Byetta and metformin for weight loss. It's just not the correct thing to do. But people do lose weight, and if you can lose weight, you can improve your insulin sensitivity, and hopefully with exercise you'll feel like doing more as the weight goes down, and your diabetes should improve. Again, these products are new to the market. They are expensive, not a lot of assurances to cover them, so they haven't really been in vogue. If you have a commercial plan, sometimes you can get them covered. Most of the time you can't, but we do like to use those because helping you lose weight is very, very important with diabetes. Let's talk a little bit about the analogs. These are insulin products. Obviously there's this is an injectable product, as most people know. We do use insulin, obviously, in type 1 juvenile diabetics, and because they make no insulin, but sometimes it's important as you get later into type 2 diabetes that you don't make a lot of insulin. In doing so, you need to supplement your insulin production, meaning the medications that we have listed before are only effective if you make insulin, and they are not effective if you do not make insulin. So one of the things your doctor should be doing is looking at a fasting insulin level to make sure that you indeed are making insulin. So if you have to be on insulin, obviously they're broken down into several different categories. I use long-acting, and then longer 24-hour acting, and then short-acting. So long-acting had been out for a long time. This is called NPH insulin, and 10 to 15 years ago, people would use a combination of NPH twice a day, and then they would use regular insulin with it. And then they tried to break that down into what they call a 70-20 mix or 70-30 mix. And what that meant is that if you took the dose of 15 units and multiplied it by 70% or 0.7, you got your amount of long-acting insulin, and 30% of that was short-acting insulin. The problem with this type of insulin is it peaks 6 to 8 hours after you inject yourself, and it lasts almost 12 hours. So if you forget to eat, you will have hypoglycemia. Hypoglycemia, when someone starts to feel their blood sugar going low, what do? They run and eat, and they eat a lot. And this causes a spike in their sugar. This is old treatment. I do not like it. It's very inefficient, and there are much better products out on the market. Now, the newer long-acting insulins, Lantus and Levemir, boast their 24-hour insulin life. And so with that, you can simulate an insulin pump by giving yourself an injection of Lantus and using short-acting insulin. And this is the better way to do it. This is a poor man's insulin. It's very, very effective, and it requires a lot of testing because you want to test yourself before you give yourself your dose when you eat. If you don't eat, your basal insulin is Lantus. It continues to work because that's what our body does. It makes basal insulin, and then it makes insulin more when we eat. So we simulate this situation, and it is very effective. And the short-acting insulins last from anywhere from 4 to 6 hours, and they can peak in 2, depending on your kidney function. The worse your kidney function, the longer these insulins tend to last because insulin is degraded by the kidneys. So therefore, the newer insulin, Apidra, which I didn't list, is a very, very rapid acting insulin. So rapid, it basically you can use it after you eat if you have an idea that you overate. And I can go into more. The next one is this alpha glucosidase inhibitors. Suffice to say, Arachibos was the name. Let me tell you, people don't like it because it inhibits glucose absorption in your intestinal tract, and its side effect is flatus. Yes, you make a lot of gas, so a lot of people don't like that. So that's why it was never very effective. Why would I give you a medication that causes you to be a fart monster? We don't want that. Okay, the next one would be these newer products, the SGL2 inhibitors. What these products do is they basically trick your kidneys into not reabsorbing sugar, but secreting that sugar. They do cause you to lose weight. The problem with that is a couple of these products may have been linked to bladder cancer, so I'm not a real big fan of that. They're new products, they're very expensive. Invokana is the one that is not supposedly linked to bladder cancer, so I tend to stay away from these products. So that pretty much covers most of the diabetes medications. I hope that there's some information there to help you. Remember, diet, exercise is most important with anything and everything that you do. I've tried to talk a lot about weight loss. I've tried to talk about proper diet. I've tried to tie it in with diabetes to let you know that it all starts when you sit down at the dinner table. If you overeat, you eventually are going to gain weight, you're eventually going to become a diabetic, and you're eventually going to have to be on some of these medications, run an increased risk for heart disease, an increased risk for stroke, early death, and so you really do need to pay attention to what you're doing and try and get some regular exercise. It's important to keep your muscle tone up, keep your body moving, and it really is just that simple. So with that, I hope that helps you, and next week or the week after, we'll try and tie all this together and talk about some other products and some other issues. Thank you for tuning in tonight. I'm Dr. Michael Reiner and hope to see you here next week. Thank you.